primary pneumothorax, primary spontaneous pneumothorax, there is no underlying lung disease, and it typically affects males who are tall and thin, and it's also associated with connective tissue disorders such as Marfan syndrome, Ehlers-Danlos syndrome, etc. And smoking is also a risk factor, they said. So it's much more common in males. The ratio of males to females is 6:1. And then secondary spontaneous pneumothorax occurs in patients who have underlying lung disease. This can be COPD with emphysema, tuberculosis, PJP pneumonia is there's quite a high association. It's a common complication of PJP pneumonia. PJP was also formerly known as PCP, and then cystic fibrosis and lung cancer. These conditions can all cause bullae that can rupture and cause a pneumothorax. How can we diagnose it? Chest X-rays are the mainstay, and usually a PA erect is the easiest, it's the ideal to detect it. If your patient cannot stand erect, then an expiratory radiograph is also, what am I saying? The normal PA erect taken on inspiration is usually good enough to detect it, but sometimes in very small pleural effusions, you'll ask for an expiratory radiograph, and if a pneumothorax is present, it will become more obvious on the expiratory radiograph. In patients who are unable to stand or to sit, lateral decubitus X-ray can be done. And unlike with the pleural effusion, for the pneumothorax, the affected side should be up so that the air can float to the surface. And then in patients now whom you cannot turn them, you can't turn them to decubitus, they cannot sit or stand, you can also detect it on supine views. And then CT and ultrasound can also be used. Right, so on radiographs, the features of a pneumothorax are that you are able to see the visceral pleura, and this will appear as a thin, clearly defined line which follows the internal contour of the chest wall. And then between this line and the chest wall, there should not be any lung markings. Those are the cardinal features. Then the lung may also completely collapse, and there may be mediastinal shift associated with it. If mediastinal shift is present, then that is a tension pneumothorax. And it's also very important to inspect the apices very carefully, because in primary spontaneous pneumothorax, that is the commonest place to see them. Okay, so would anyone like to, can you find the pneumothorax in this image? Yes, please.
Yes. So on the plain radiograph on the left, what's illustrated by the short black arrows, if you look closely, you can see a faint opaque line, yeah? And then lateral to it, okay, I can't really comment on the lucency of that aspect, but that should be the area where we have the pneumothorax, but it extends from the apices all the way to almost the base, but like let's say upper 2/3. But you can see that line.
What do you call that line? The pleural line, visceral pleura is the pleural line. And lateral to it, what are you saying? If you can magnify the image or zoom in.
We've said we won't see any vascular markings, so we are not seeing that.
Yeah, that's the main thing. Yeah, so you can, yes, when you zoom in, you can see it quite clearly. You can see the pleural line, and then beyond that, you don't see any vascular markings. So
Yes.
that definitely is a pneumothorax. Then the other one.
Yeah, so we need to look very carefully at our images, otherwise this you could easily miss this. Right. And then the image to the left.
So the image to the right, we are looking at a PA, chest X-ray, chest radiograph, and on the left hemithorax, we can see complete lucency with the left lung that looks like it's collapsed, and that area can be seen adjacent to the left heart border. But the opposite side, the right side, we can see the normal, a normal appearing right hemithorax.
What's also important is talk about the mediastinum.
Um, Now, it doesn't look shifted.
Yeah, that's important. There's no mediastinal shift, isn't
Yes,
it?
that's not shifted.
Because once there's mediastinal shift away, then you're talking about a tension pneumothorax, and that's an emergency.
All right.
Thank you, Sharon. So yes, I wanted to put these images side by side just so we know, so we remember to always inspect the lung margins closely because you can miss the pneumothorax. But this one is, yeah, this you can't miss this one. Okay. The images to the right, to the left, is someone volunteering, or should I? I thought someone was.
I think can go ahead because it's similar to what Sharon has just reported.
Yes, this is showing the effect of an expiratory radiograph. So in A, this is the patient's first X-ray, and there is a pneumothorax, and then an expiratory radiograph was done, and now the pneumothorax is much more visible because the lung has collapsed a bit, has moved away from the chest wall, and so because of the air and then the image to the right is showing the appearance of a pneumothorax on a decubitus X-ray. So this is our visible pleural line, the collapsed lung, and above that, we have this lucent space without any bronchovascular markings. More tricky, but you can also see, but you can also detect a pneumothorax. The important places to inspect are the anteromedial, posteromedial, costophrenic, as well as the subpulmonary spaces, because these are all areas where air can accumulate when the patient is lying supine. And it's also important to note that we can also detect a tension pneumothorax on supine views. So the features that are suggestive of a pneumothorax on the chest radiograph, or sorry, rather what you should look for when you're inspecting the basis of the chest X-ray are a hyperlucent upper quadrant of the abdomen. That might be suggestive. And then air situated in the lateral costophrenic sulcus. That creates something known as the deep sulcus sign. If the dome of the diaphragm is sharply outlined by air, that is also a sign of a pneumothorax. And then if you're able to see both the diaphragmatic dome as well as the anterior portion of the diaphragm, which is known as the double diaphragm sign, that is also suggestive of a pneumothorax. And to the right, because nothing in medicine is ever certain, is just a list of differentials. So these signs that I've listed here in the right setting might be a pneumothorax, but it could also be something else. So such as could just be lung hyperinflation or subphrenic abscess, perhaps a bully or free peritoneal gas. They may all mimic attention pneumothorax as well. But if you have a patient, let's say an ICU patient, critically ill, who is not getting better, who's becoming worse, and you see one of these signs, then it's more likely to be a pneumothorax as opposed to one of the other differentials. Whereas if you see one of these signs on a patient who's otherwise well, maybe just came for an X-ray for medical checkup, then you're more likely to think of something, for instance, like a MAC band or a skin fold.
Yeah, what are match bands?
Match bands, they said, are hyperlucent lines that you get on chest X-rays around curved surfaces.
Okay, and they can mimic
Yes, they can mimic.
pneumothorax. Yeah.
Okay. Oh, is there
Yes,
someone
Derek?
volunteering?
Yeah, I think he wants to report the image.
Yes, please go ahead.
Not really. I was asking the match bands.
Mm-hmm.
The way I understand match bands, maybe can you describe again?
Well, let me just show you the image, and I haven't put images of the match bands themselves, but I will show you the signs as we go along, or what could be considered a mark sign.
Okay.
Okay. All right. So, for instance, this is an AP radiograph in the supine position of a patient who is very unwell. We can see that they are intubated, and what we see is that on the right hemithorax, we have this hyperlucency extending deep into where the costophrenic angle, deep into where the into the costophrenic recess. We have this extension of air of hyperlucency, and then there is also the outline. The cardiac border is also well outlined by air.
And I think,
And
yeah, those are the signs, isn't it, right? So you
yes,
have increased lucency of the right hemithorax compared to the left side.
the left
Then you've
side.
talked about the deep sulcal sign
This is the deep sulcus sign. Yes,
when you compare to the
this.
contralateral side.
Mm-hmm.
Then the medial margin, the margins of the mediastinum are sharply outlined.
Yes,
Yes, all that will tell you that what you're looking at is a pneumothorax in a supine
pneumothorax.
patient. And it's something you need to look for, especially in the pediatric radiographs, right? Because
Mm-hmm.
the radiographs will be taken AP and they could be actually having a pneumo and hence
Mm-hmm.
worsening. And
Yes.
that one needs to look for these signs.
Mm-hmm. Yes. There's also this lucency over the right the right upper quadrant
Yes,
compared to the left
that
side.
increased lucency. And if you follow that lucency, it actually outlines
The
the shape
lung.
of the pneumothorax.
Yes,
Yeah.
it does.
But remember, there's also a lucency that you might see in a pneumoperitoneum. When you look
Mm-hmm.
at the liver shadow and you're seeing one area
Yes.
is more lucent than the other, again, that would be
Mm-hmm.
pneumoperitoneum. Yeah.
Yeah. On the left side, can anyone remember or can you diagnose what's happening on the left side? For instance, Derek.
No one has put up their hand. Any volunteers?
The
Okay, go ahead.
topic we just discussed, that there is increased opacification, there is opacification of the entire hemithorax, and we're able to see the normal bronchovascular markings. No signs of consolidation, air bronchogram. So this patient
Yes,
also
Sharon's
needs
hand is
a
up.
pleural effusion on the left side.
Yes, Sharon. And there's also, yeah, blunting of the costophrenic angle. And you actually
Mm-hmm.
cannot see the hemidiaphragm on that side.
Yes.
Yes, Sharon.
Oh, yes, I wanted to say that pleural effusion.
Okay,
All
great.
right. Thanks, Sharon. Yes, and then this image here is also demonstrating a right-sided pneumothorax, which is, so what we see is that the right hemidiaphragm is sharply outlined by this hyperlucent line. And Derek, this a mark A march band could also look like this, could have this type of appearance in this place as well. So in a well patient, for instance, someone who just came to get a chest x-ray for a medical checkup, otherwise fine, then this would be a march band. But in someone who is critically ill, unable to sit, it would be a pleural a pneumothorax. Then this chest radiograph is demonstrating the double diaphragm sign. So what we are seeing is that we are able to see the dome of the hemidiaphragm as well as anterior. This bit here is the anterior portion of the diaphragm. And so this is referred to as the double diaphragm sign.
So you have double diaphragm, you have also deep sulcus sign,
Mm-hmm.
and you also have a continuous diaphragm sign.
Is it?
Yes, but I think we covered that in abdominal.
Because
Yes.
double diaphragm would imply pneumomedial.
No, but you have a pneumomediastinum. But now, but I think don't we have a right?
No, because I think it's supposed to be
It's not visible.
the main level, right?
On the right side, you don't see it. You see on the right side medially.
The diaphragm.
Yes, there. Just where the heart is, you don't see it, but you are seeing it much more with more clarity on the left side. So it's not continuous.
Yes.
But you can get continuous. In a pneumomediastinum, if there's a pneumothorax, yes.
Mm-hmm.
Yeah. So again, you look at the entire clinical picture. Yes, Sharon.
Just a clarification, because the left hemidiaphragm looks almost similar to what I remember us seeing in it's a subpulmonary effusion. So could you please illustrate again the double diaphragm sign on this so that I can see if I can differentiate the two?
Right, Taleni?
There's no double diaphragm sign with the...
No. She's saying
effusion.
the diaphragm looks like subpulmonic. So show her the two aspects of the diaphragm. But what is really clearly seen in this supine radiograph on the left side, one, you can see the deep sulcus sign.
Yes.
And then two, you can see there are actually two margins to that diaphragm. One is anterior and one is posterior. And the posterior one is actually everted. It's deepened. It's concave as opposed to convex. So you have a convex diaphragm and a concave one. Can you outline them, Taleni?
This one?
No, not the rib. I thought it goes and plunges down suddenly. So yeah, go up. Oh, well. Start from medially. Taleni. Medially. Then from there, you're going fast. So just go back, Taleni. Up. There, the two leaves, the diaphragm now divides. There's one that goes downwards rapidly,
yes.
and there's one that goes, has the more of a normal contour. And you can see the one that goes downwards deep, rapidly is what I'm talking about. It's like an inversion. And if you have a lateral view, it's where you'd see that everted or concave diaphragm. And you tend to see that as well, like in pediatrics where you have, but also here, you're seeing you're not seeing lung markings all the way, but in pediatrics where you have air trapping, you can actually have the diaphragm having this kind of shape, but it will not be double. Okay? Yeah.
Okay, so that was the lung base. The other place we need to look carefully is around the borders of the heart. So what we might see there is a deep and well-defined anterior cardiophrenic sulcus, which may be the earliest sign of a small pneumothorax. We may be able to see a sharply defined cardiac border as well, which is what we are seeing in this particular image. So in an acutely ill patient, this could be a sign of a pneumothorax, but it could also just be a march band. So Derek, a march band can look like this as well. And then a sharply defined pericardial fat pad and a sharply defined margin of the anterior junctional line. All right, so this is a chest radiograph demonstrating the medial sign. So we have this radiolucency outlining the cardiac border, and we also have a deep sulcus sign and the outlining of the left hemidiaphragm.
So the first thing when you look at the chest radiograph, the first thing you can see that the left hemithorax is more lucent compared to the right.
Yes.
And then you can see the left cardiac border is sharply defined. And then you've talked about the deep sulcus sign, and all those add up to that there's a pneumothorax. And there's a mediastinal shift. Huh?
Mm-hmm.
Yeah.
Yeah, so this will be a tension pneumothorax.
Yes.
Yeah, for this image, the left hemidiaphragm, wouldn't you describe it more of the sign of where the double diaphragm sign rather than deep sulcus?
You can use all terms are applicable. You don't have to use one or the other. So for instance, it is being sharply outlined, and then it's also going deep into the costophrenic sulcus.
So you mean to say those terms are interchangeable? Because so far
No,
when
not
I've
interchangeable, but you can all of them apply. It doesn't mean if you say double diaphragm, then you can't talk about a deep sulcus sign.
Okay, so in this particular radiograph, which sign are we seeing?
seeing in the left hemidiaphragm?
There's a deep sulcus sign, as well as the anterior diaphragm sign.
This was
And also the sign
sulcus,
about the hemidiaphragm being outlined by A above it.
and what you can see is that you can see where the left costophrenic angle ends, right? Because it's really deep. It's even within not the cone area as compared to the right side, right? And I think that is one of the main signs when you want to talk about supine pneumothorax. Actually, that's what you really look for, a deep sulcus sign. The others are additional.
oh, okay.
And this is demonstrating the air that appears to be behind the shadow of the heart. So this is also suggestive of a pneumothorax, and this would be A in the posteromedial recess, but it's quite rare. Okay, then so a medial pneumothorax, one of your main differentials would be a pneumomediastinum. So I've just listed here some of the things that differentiate a medial pneumothorax from a pneumomediastinum. So medial pneumothorax, the A is within the mediastinal pleural cavity, whereas in the pneumomediastinum, it's in the mediastinum. It's A spreading that outlines the structures within the mediastinum. And for the medial pneumothorax, the A is confined to one side of the heart, whereas with the pneumomediastinum, you'll have both sides of the heart will be outlined. If you reposition a patient with a medial pneumothorax, perhaps if you put them, let's say, in a lateral decubitus position, then the A will change. It will repositioned. Whereas with the pneumomediastinum, repositioning is less likely to affect the
it's less likely to affect the distribution of the air because there's less space for the air to go to. Unlike with the pleura where it will go to the most superior portion of the patient. Then the anterior junctional line is displaced towards the unaffected side, but that does not happen with the pneumomediastinum. And then there's no mediastinal shift with the pneumomediastinum, whereas with the pneumothorax, you can have a mediastinal shift. Then the tension pneumothorax, the two important signs are highlighted here in bold, that there's the mediastinal shift to the unaffected side, although it is said that in patients who have like restrictive lung diseases, there might not be any mediastinal shift present. And so one of the most sensitive signs is actually flattening of the hemidiaphragm. That is an important sign of a tension pneumothorax. So ipsilateral flattening of the hemidiaphragm, and then if the patient's like pathology allows, then the mediastinum can shift. The first X-ray here is of a PA radiograph in an erect patient, and what we see is that there is lucency of the left hemithorax. We cannot see any bronchovascular markings at all, and then medially we have this structure which represents the collapsed lung, and then the mediastinum is also shifted towards the right. So this is a tension pneumothorax. The hemidiaphragm is also flattened.
Yeah, right. What do you think about the lung volumes also, in terms of what was the underlying disease in this patient? And even the cardiac outline size?
An emphysematous process, because these lungs are hyperinflated.
They're the hyperinflated. And even the...
I think fibrosis or...
Yeah, emphysematous. Then there can be mainly emphysema, and even the cardiac outline, it looks small, eh?
Yes.
It's on the smaller side, yeah, okay.
Right, and then this patient, this is a supine, a radiograph of a patient in the supine, taken in the supine position. So what we see is a deep sulcus sign, and there's also mediastinal shift, although it's not slight, there's obvious mediastinal shift in this patient. So this is a tension pneumothorax on a supine radiograph. The hemidiaphragm has not flattened, but there's mediastinal shift.
Yeah, what has made you sure that there's mediastinal shift in terms of the cardiac shadow? How much should you see to the right side of the spine?
Oh, only very little. Only the
it's a third.
Right atrium.
A third on one side,
A third.
2/3 on the left. Yes, and you can see here it's the other way around. You're having 2/3 on the right side, so you know there is mediastinal shift.
All right, and in this image, this is demonstrating a tension pneumothorax in a patient that has a bullous emphysema. So only one, how should I put it? Only one segment of the lung has the pneumothorax within it, and yes. So only this particular, so you don't always have to have the entire lung being affected, is what I'm trying to say.
So I think these are two different processes you're talking about. Because the pneumothorax, the pathology is within the pleural space, while a bullae is within the lung parenchyma. Yeah. So do you have a ruptured bullae here with the pneumothorax? Because I'm seeing there's a deep sulcus side.
Yes. They say it was a ruptured bulla.
Yeah, so you can see there's the lung itself has bullae within it. Yeah, and you can actually see there's what's arrowed is a margin, is a pleural line, the visceral pleural.
Yes.
And plus now the other signs you want to talk about, the mediastinal shift. It's quite marked. Yeah.
Yes, this marked mediastinal shift. Then the image to the right is just demonstrating after an ICD was inserted, and then the mediastinum has returned now to its normal position, but
it's returning.
It's returning, yes.
It's already returned, but there's some lung re-expansion, isn't it, right? Because you can see there are lung markings. Well, next to that chest tuber, in the right costophrenic area. It's still bulla. The lung still has a bullous change.
Yeah. Okay. So that was radiographs, and then on CT, a pneumothorax is also can easily be detected by using examining the lung windows. So yes, this is an axial CT through the chest demonstrating a pneumothorax. So we see this is the lung. It has collapsed. It's not reaching all the way to the chest wall as the right lung. We have this hypodense region.
Which lung? Left lung.
The left lung, yes, the right.
Yeah. So get used to right, left, huh? Okay.
Yes. And then the patient also has air outside the pleural cavity in the subcutaneous tissue. So this is subcutaneous emphysema, and there are also rib fractures.
Is that subcutaneous or soft tissue?
Oh, soft tissue.
Yes, yeah. Call it soft tissue if it is deeper than the subcute layer. Yeah.
And then, just a coronal reformat of the same patient, demonstrating the pneumothorax, and then the soft tissue, the soft tissue emphysema. Right. Should we continue? It's 9:30.
How many slides do you have?
There are still a lot of topics to go because there's pneumomediastinum, then lung contusion.
Then we can stop
fractures and sternal fractures.
How many slides do you have for? No, we can stop there. I think we can stop there, isn't it? Huh? Well, what's a consensus?
We should stop there.
I think so. People are saturated. So let's stop there and then we can continue next time. But thank you very much. Christine?
Hi, Dr. Sorry, I'm on call, so I wasn't able to follow the whole discussion. But I wanted to consult on one case if it's okay.
That's fine.
All right, thank you. Maybe I can just share. It was a patient who had a CA esophagus, has been a smoker for around 8 years.
Telani, you can stop sharing. You have images to share, Christine?
Yes, I do. So we have 3 sets of images, but my question was mostly just on the lung window for this patient. So he's a 61-year-old CA esophagus in the lower third of the esophagus and emphysema with a history of smoking. So this was a lung window, and these were the changes that were visible. They're seeing the emphysematous changes septal and some are centrilobular. This was the initial one. Going all the way down. And so now it was larger once you went to the lower zones. But my question initially was...
It actually has almost even the panlobular type, huh?
Okay.
Emphysema, yeah. Were you asking if this is a bullae?
No.
You continue that.
So my question was mostly on this apex, at this area. And would this be a mass? Because on all 3 images, they were all there, but it was not reported, so I wasn't so sure. This one is
Have you changed the windowing? Can you change the windowing?
I put it
to soft tissue because you're asking, is that a
mass?
mass?
If it's a mass,
Yes.
The best I can do is the abdomen.
That's fine.
This one. Yeah.
Okay, so they definitely did lung settings.
Yes.
Okay, let's go up. Let's see, up. Go down slowly now.
Christine, is there mediastinal window?
Yes, doesn't have
Is the image next to the topogram?
This one, but here's the mass on this one.
Yeah, there's something there. There's actually something there.
Yeah.
Plural based.
Yes. This one here, and the Hounsfield units on the center. So giving me negative units at around negative 20. On there, at the edges, we're giving me positive values, but just to 30.
So it could be volume averaging. But you can mention that there's that focal plural thickening. Okay. And comparing if it's a mass and what else? Because he has C esophagus, isn't it?
Yes.
So that's esophagus is just air filled, right? Where is the mass on the esophagus? And why did they do a lung window? Why did they not do a CT chest with contrast?
They did.
Oh, here you are. Then yes, there you are.
Yeah, right here.
Okay, and I think that's what Talen was asking about.
Yeah.
There's a mass there, but it doesn't look like it enhanced.
No.
And it looks like it could be fat then.
Yes.
I guess that's why they didn't really bother about it because he has bigger problems when you go down,
Yes.
Yeah, and the main thing I think they were looking for in that window, that particular window, were for mets.
Mets, yeah.
And all that we saw was just so. Where is the esophageal mass?
Esophageal mass. This area.
Yeah. Okay.
Yeah.
So it's markedly thickened. Okay.
Yes.
Right.
Yeah.
The question was.
Sorry.
The question was.
Oh, it was just to confirm if that was the mass that I was seeing, or maybe I'm just forcing it.
Yeah, there is a focal plural thickening which does not enhance, and yeah.
All right.
And it's better seen, really, not on this window.
Yeah.
In this other window, yeah. Whereby, if you look at it, it could look like fat.
Fat. Yeah.
Yes. Because you can look at it has the same density, just eyeballing it, as on the contralateral side. Yeah.
Yeah. Okay.
Because remember, when you're also doing measurement, you do get averaging, yeah? Okay. But you can also look at how it looks on a corona and things like that. Yeah, and I think one can feel also confident in terms of you're not seeing anything enhancing, yeah? Because if it's a met or another something else going on, it should have enhanced, yes.
Okay. All right. Thank you, Doc.
Okay, you're welcome.
Yeah, Dr. Thomas, before you log out.
In your whatevers. So before we log out, yes, Derek?
Yeah, you know that will beg the question if there are any notes in the chest. That's very important now because I don't know if you found any notes like all the nodal stations by GCC or American Thoracic Society.
Okay. I don't know. Did you do that, Christine? I didn't see in the rapid whatever just going through, I didn't see any notes, any large notes. But I think that one needs to actually do that in terms of staging. Though I don't know why you are staging at night.
No, we are just asking.
Yes. Because you really need to go carefully and ensure that there are actually no enlarged nodes. And again, as well, pulmonary mets. Because the main thing that I saw, just looking at it overall, I just saw just the emphysematous changes and the different types of emphysema.
No, I brought it up because I know if Dr. is going to mention it, it should definitely be asked about nodes and
oh yes, yeah.
Any meds, those kind of issues. Yeah.
Yes, definitely. So, Christine, was your question answered? Were you supposed to report on this city, or you were just looking at it?
Sorry, Doc? You're asking me a question?
The city, was this an emergency city?
No. This is for my cardiothoracic committee tomorrow.
Wow.
Yes.
Right, then we're going to be asked about nodes.
Yes, no, there were no nodes. No
Okay.
nodes, enlarged nodes.
But it's lower. Did you look at the upper abdomen?
Yes.
So the left gastric was okay?
Yes.
Okay.
That was okay.
The station was fine. All right.
Yes.
Okay, great. All the best.
Thank you.
All right. Have a good evening, everyone.
Good evening to you too,